look at the side effects. The side effects is angioedema is less. Recently, I've seen a patient who had angioedema 3 times. And somehow the patient was on sacubital valsartan, and nobody suggested him that this could be due to sacubital valsartan. So I stopped the drug. He's fine now, no more angioneuritic edema. And so this is one of the complications that can occur. You have to keep a watch and advise the patient that any symptoms or any signs that you feel that this is angioneuritic edema, you should stop the drug and consult the physician. And of course, hypotension is more common vis-a-vis enrapil. You can see it is around 18% overall, or 12% enrapil. Impaired renal function is seen with this class of agents, but is still low, 3.3%. Hyperkalemia is 12%, bit less than with enrapil. And cough is there, but it is less than enrapil. Around 9% will have some cough. And when you see the risk of potassium, they look at the potassium level. The risk of hyperkalemia appears to be lower in sacubital valsartan vis-a-vis enrapil. So hyperkalemia incidence appear to be less, and incidence of severe hyperkalemia appears to be also less. So this is enrapil. So this is our sacubital valsartan. The incidence of overall hyperkalemia and severe hyperkalemia appears to be less with the use of sacubital valsartan. Coming to the contraindications, as I told, within 36 hours of ACE inhibitor use, you simply cannot use this drug. History of angioedema or with or without an ACE inhibitor, you cannot use it. Pregnancy, lactation, severe hepatic impairment, concomitant aliskiren used in patients with diabetes, and patient having a known hypersensitivity to either R or RNAs. You should be careful about patients with mild to moderate renal impairment. There's no need to adjust the doses, but with eGFR less than 30, you should start with 50 mg twice daily and double the dose bit slow every 2 to 4 weeks to target a maintenance dose of again 200 mg twice daily. Remember, in the eGFR less than 30 also, the target maintenance dose is 200 mg twice daily. Only that you have to approach that dose at a slower rate. In hepatic impairment, mild no dosage adjustment required. Moderate starting dose 50 mg twice daily and double the dose again slowly 2 to 4 weeks. Again, the target dose is 200 mg twice daily. You have to cautious in patients in renal artery stenosis, systolic blood pressure less than 100, and in patients who are volume depleted, because here the risk of hypotension is quite high. Drug interaction that is contraindicated with ACE inhibitor, aliskiren. Potassium sparing diuretics may lead to increased risk of hyperglycemia. So, particularly patients with renal impairment, diabetes, hyperaldosteronism. So, you have to be careful when using along with a mineral receptor antagonist. You have to monitor potassium level. And non-steroidal anti-inflammatory drugs are has a worse outcome when you use it in patients with heart failure in general, particularly. So, you have to avoid that. And again, the patient, they do have other side effects. So they are a class of agents should be avoided in patients with heart failure. And somebody on lithium, there is increased risk of lithium toxicity and birth control pills also.